Dear colleagues, we go on in the program, and the first event will be the live case.
Do you hear me?
Yes, we can hear you.
Excellent. I just came. Our colleagues have done 90% of the job together, Dr.
Yes.
Stankov and Dr. Cesna. And I would like to ask them to tell us what you have done. I know more or less, but it's better they to tell you.
Yeah, so we did some work, and if you could present the data of the patient, we can
Yes.
firstly go through the procedure itself.
In fact, I expect Dr. Vasiliev Strahu, he's with you, Klaus, in the room. So he will present quite a challenging case of a young lady after operation for tetralogy of Fallot at her infancy. And there are several very important details. Is Dr. Vasiliev ready to present the case?
No, you don't have micro.
Okay.
Can you hear me, Professor Petrov?
Yes, we hear you very well.
Yes,
Go
I'm
ahead.
ready. Can we
Go
put up
ahead.
the presentation, please? Yes, thank you.
Yeah, great.
So basically, we have a 50-year-old female patient with a complex congenital heart disease. She is with tetralogy of Fallot, which has been corrected in the past when she was newborn, after that as a child, and so on. And also she has a pulmonary atresia, and is presented to our hospital like maybe a month and a half before that time, with progressive dyspnea, palpitations, basically heart failure patient. As you can see, the first operation was a Blalock to shunt. After that, with radical repair of the tetralogy, reduced surgery with right ventricle outflow tract conduit, and after that, a prosthetic valve endocarditis, which was successfully treated conservatively. Right now, the patient is with severe pulmonary stenosis of the pulmonary conduit. You can see that the gradients are pretty high, and also there is severe regurgitation, very dilated right ventricle with right ventricle dysfunction, and of course tricuspid regurgitation with severe pulmonary hypertension. What we did, firstly, we decided that the patient is very high risk for redo operation, which will be her sixth, I think, operation. So we decided that melody valve implantation is the best step for us and for her. We did the CT, which, as you can see here, revealed the dilatation of the right ventricle conduit, a very important finding that the osteoproximal part of the right coronary artery is located very closely to the right ventricle conduit, as you can see here. Basically, a pretty interesting challenge for implantation of a melody valve because of the risk of the compression of the right coronary artery. Here you will see the 3D clip of the coronary arteries. The one that is going to come towards us right now is the right coronary artery with the conduit right next to it. This is the NGU, left coronary system, perfectly normal coronary arteries, and this is the right coronary artery. Even here you can see the proximity of the conduit. And as I told you, the heart team decided that going with melody valve implantation in this high surgical risk patient is the best part, So yeah, that's it. Now I'm leaving to Professor Petrov and Docent Stankov to show the case. Thank you.
Thank you, Dr. Vasiliev. So, as Dr. Vasiliev mentioned, there are several details very important. The anomalous right coronary artery and the risk of compression by the valve after the implantation, the huge calcium burden and the risk of rupture, like Dr. Cesna showed in his presentation. This is one of the risks during the Melody valve implantation, and because of that we are prepared with a stent graft. In fact, we are using the same stent grafts that we implanted in the two first cases several months ago. This is the Bentley aortic graft, stent graft. And I'll give you now the floor. Yeah, Dr. Cesna will explain what was the progress before I'm coming.
All right. So the main worries before the procedure was that we may occlude or compress the coronaries, and for that reason we selected to do a selective angiogram. And also there was a risk of the conduit rupture, because this is a very severely calcified conduit. So here you can see the aortogram, which didn't show anything important for us. Next one. And this is the angiogram from the right ventricle. And here you can see just above the pigtail there is a chunk of calcium, and this is the conduit with a valve. And above that we have a healthy pulmonary artery which is quite dilated. So we placed the distal part of the catheter and the distal part of the wire in the left pulmonary artery, and we have one catheter in the ascending aorta and one in the right ventricle, just to do the angiograms. Next one. And this was the dilation with Andra balloon, 24 by 40. It was difficult to cross even with a balloon on this Lundquist wire, which is positioned in the left part. All right, next one. And this was the dilation with the balloon, and we did the soft inflation of the balloon and did the angiogram, and we can see just between the balloon and the aorta is we can see the coronary.
The right coronary, yeah.
Right, but the balloon is still not opened quite well. We don't really know what would happen if the balloon will open more. Next one. So we tried to do a post-dilation with a balloon. We changed the catheters for the selective angiogram. Next one. And this is the second inflation of the balloon with the selective angiogram. The problem was that the balloon ruptured, and we couldn't do the evaluation of the coronaries. So Andra 24 by 40 ruptured. So we decided to go with the Atlas Gold balloon and do the same angiogram with selective injection. Unfortunately, the Atlas Gold balloon ruptured at the 8 atmospheres, which is not very usual thing. And you see that the chunk of calcium stayed in the place. So we took the second Atlas Gold balloon and we inflated up to almost 20 atmospheres just to have the good inflation of the balloon. And then we did the selective angiogram. All right, next one. Yeah. So this is the injection with the inflated balloon. So this is the inflation, and you can appreciate that the calcium is just at the ostium of the right coronary. Next one. Next. And this is the angiogram itself with the inflated balloon, and we don't see any coronary compression. So we thought that it's good to go with and proceed with the case. All right, next one. So we went into with a 16 French 80 centimeter length of the teeth, and we crossed the lesion and we positioned the tip of the delivery system at the bifurcation. All right, next one. And this was the positioning of the Bentley 22 by 48. All right, next one. So we implanted the stent and we tried to cover the whole length of the calcification from the inflow part up to the top part. And here we can see that there was very nice positioning of the stent, and it opened quite well. Next one. We did the angiogram just to see is there any rupture, because there was a higher risk, and then we post-dilated with Atlas Gold 24 by 40 balloon. And it opened up to, again, up to 20 atmospheres. Next one.
You see the coronary is perfectly open. And now it's a different situation because the stent graft is already the landing zone.
Correct.
It's not so. In fact, we make like a good landing zone for the melody valve to be implanted securely without risk of any more compression.
Correct, and we will prevent the melody valve from the calcification and from the compressions from the outside.
Yeah.
All right. So this is our final result until now. We have a very well positioned stent. We have no compressions on the coronaries, and we are ready for the melody valve itself.
Absolutely. Yeah. So we are going to crimp.
So we have a delivery system here. Can you see our hands and the images?
Try with the central camera to show the table.
We have a camera right here.
And we have also, yeah, okay.
All right. So we have a delivery system for the melody valve. At the top part, we have a carrot balloon, which is a bib balloon, and we have a coverage for the valve. On the other part, we have two balloons. So the orange one is the outer balloon. The green one is for the wire, and the blue one is for the inner balloon.
Exactly.
So we are going to take the valve out of the box. Yes, 22 valve. So 22 valve gets the length of the dimensions of 24 outside. So that's why we try to position the stent frame up to 24. Can we check the number? That's K122789. Perfect. So this is the valve, how it looks like. We have to play with the valve and flush the formaldehyde and play in the bowl. So as I mentioned during my presentation, this is a CP stent, 8 zig, with a bovine jugular vein, which is sewed inside. So if we could see, this is the very thin leaflets of this valve. So that's why
during rinsing, you are checking, in fact, the apposition and the cooptation.
I don't do that because it's not recommended. Otherwise, we will throw half of the valves outside. But these valves are inspected in the laboratory, so they go through lots of tests. We have to rinse them and flush just to get rid of the formaldehyde.
Excellent.
So we will play 2 minutes in one bowl. I will take this suture line, not leaving on the valve. And then we are going to crimp the valve. So the valve itself has a blue line on the distal part, which should be facing the bifurcation, and the white end is the inflow part of the valve.
Yeah, exactly.
All right. All right, we'll go to the next bowl. And again, 2 minutes of just flushing and playing with that. For that reason, we have some time for chat or some jokes. I think we used all the jokes before the live transition.
Probably now is a good time for you to have question and to raise question if you want, if you have.
Can we get a smaller syringe? 2 cc's?
Yes. Are there any questions? You have one. So,
Ivo?
Yes.
Can you give us just an idea? Why did you choose a melody valve? You may choose some other balloon expandable. As far as I know, with this size, you can both use MyVal or even Sapien. So what's the reason for choosing?
It's true. In fact, you know very well that both Sapien and MyVal on this position is off-label. It's possible. Also, Dr. Cesna have shown in his presentation. But in fact, the valve that is approved for this position nowadays in Bulgaria is the melody valve.
Also, this is the valve that has the longest follow-up data on the market.
It's even longer than the nowadays TAVI valves.
Yes.
So the experience with the melody is the longest one, and because of that, this is the approved with this indication valve.
So what I did now, I put the small syringe and I put the valve just to make it slightly smaller than it came out from the box.
Yeah.
If you can hold the distal part of the delivery system. So again, I'm placing the valve on the balloon by hand, And this is the rule that we all have to
Blue to
agree
blue.
that this blue line is going to blue caret and the white is going to the distal part.
Absolutely.
And now I'm going to crimp the valve, trying to elongate the stent. So this is the elongation of the stent frame on the balloon. There are the markers that we will see on the screen, and we should stay in the middle of that. So I shouldn't compress too much. I just need to elongate and milk it, the system, trying to place into this delivery catheter. So we are not using any sheath. It's going to be a single delivery system without anything. All right, now we will go and we will cover the stent. Let me check.
Yeah,
Yep. Go on.
I'm going.
Go on. Go on. Go on. Go on.
Yeah, there is
Go on. Go on.
some resistance. Excellent.
All right. Wait a minute.
Yeah,
We
we
have
are.
to flush.
Yeah, we are the sleeve over
Yeah. So I will.
already. We are flushing the dead space now
All right.
between the sleeve and the valve.
I will kick all the bubbles out,
Yeah, because
and then it's done.
to expel the.
So this is
Yeah.
the covered. So this is the covered valve, and we are
Exactly.
ready for the implantation.
Absolutely.
All right. So we can leave this on the table until we will remove the sheath from the groin.
Yeah, Dr. Stankov is removing the sheet and bringing the valve.
I'm waiting for the valve.
Okay. So,
Be careful with the wire. You
Yeah.
need still a good position.
Yeah.
So the idea is to implant this melody valve just in the middle of the stent where
Yeah.
we have the biggest, the best landing zone.
absolutely, this is the.
Sorry, Ivo, what we
Perfect.
see on the
Yes.
screen is pressure in the pulmonary artery or systemic pressure.
No, this is the pressure in the ventricle.
Right.
That's the right ventricle pressure. So we had the high gradients and the high pressures in the right ventricle, but we removed the blockage of the vessel of the pulmonary artery, and now we have a very nice pressures in the ventricle.
I'm coming with the valve, as you can observe, slowly without too much push. Push-pull technique, the famous,
Yep.
the famous push-pull technique. Pull a little.
We can make a loop in the atrium if
Yeah.
needed. Yep. Yep.
This is after the loop,
That's
Yeah.
good. Good. Now we
We
remove the loop.
several millimeters back.
Yep.
Go up.
Yep. So now
So we are going to inflate consecutively the inner balloon. After that, okay, we are positioning, stabilizing.
I'm opening the coverage of the balloon.
Okay,
Push the delivery system slightly in. So the balloon is open now. Now we have to find the best position. So
Let's
there is
say-
no rush. We can inflate the inner balloon first, and then
Exactly.
we'll check the position if
So
we are
now-
not happy.
we have removed Dr. Cesna have removed the sleeve and the balloon is already exposed.
Yes. So
So-
we're ready for the
so we
whatever you
can-
tell us. we
Yeah,
can
go
inflate.
ahead with the inner.
So this is the inner. I think we are happy with the position. Lock the
Well,
syringe,
absolutely stable
And-
system.
and I'm going with the outer one.
Go.
Push,
Okay,
push,
I'm
push, push,
pushing, I'm pushing. Second
Great.
one.
and that's it.
Great.
All right, deflate the inner one. So we have a perfect position of the valve.
Yeah, it just in the middle of the landing zone.
Yes. All right. There is no rush.
No rush. We wait until the
The
balloon
patient is stable.
and
No, leave it. Leave it.
yeah, negative. Exactly.
All right. What do we have on the screen? All right. We will take a 16 French sheath again, whatever we had on the table.
Yes.
Гъсто.
Дилататор ще служи, да.
And I think we can pause the late with Atlas Gold because we still have it on the table just to get the best
Absolutely.
opening of the valve.
Okay, we are going to remove now the delivery system to put the 16 French.
Yes. So we are going down to the IVC and then we will cover the delivery system.
Okay.
All right, careful with the carrot.
Absolutely.
Very slowly.
Yeah,
very
this-
slowly.
The nose is already
All
outside.
right, and now we are going to cover it.
Okay.
All right,
Yes.
good. And
Okay.
now ready to go out?
Yeah, go.
All right,
We are
good.
taking now the 16 French. And after the Atlas Gold.
Meanwhile, we can prepare the catheter for the injection just to see is there any dissection. It shouldn't be because we already have a covered stent implanted, and also the melody valve itself, it's also covered in the whole length.
Absolutely. Okay. Давай поли, баллончето. We can make a control injection.
Yep, we have pigtail already in place. Perfect.
Yes, okay. Okay, let's see.
All right, looks good.
No rupture, no leakage. Okay.
So with the melody valve, I think as in most of the pulmonic interventions, just to get the stent and the delivery system in place is the most difficult part. But when we opened this stenosis, when we did the predilation and positioned the stent, the rest of the procedure usually is quite smooth.
Yeah. So we are proceeding with the balloon Atlas on negative pressure. We are not jailing the pigtail there like this.
Yeah.
And we are ready to inflate.
All right, wait a minute. I will prepare myself.
Yeah, a little volume, and after it, atmosphere.
All right. So what we do usually, we increase the. If you see my hands, we increase the pressure in the deflator. Just be preparing for the
And open.
and open. All right. So now I can do all the work. If you will keep the eye and hands on the balloon,
Yeah,
that would be good. Can you go deeper because this is the nose cone of the balloon?
Yeah.
Still. All right. Deeper.
Okay.
Deeper. A bit deeper.
Yeah.
Right here. Good.
Between
All right.
markers.
Correct. So tell me when you're ready.
Oh, I'm ready. I'm keeping.
All right. I'm giving the volume now,
Okay.
and now I'm giving the pressure with the indeflator, which is already quite open.
Okay.
We have enough space up.
Yeah,
And
because the pulmonary artery there is dilated, so there is no any risk of anything. Okay.
We can still post-dilate the
Yeah,
flow part as well.
just a little. I think this position is very good. You can go.
All right. Inflating.
Yeah, go.
Inflating.
Yeah, definitely. It moves.
And I think it's 20,
Пагу запомняме. Okay.
22 atmospheres.
Okay.
Good.
Good.
Can you damage the leaflet of the valve when you inflate them?
No, in fact, no.
Because we are not oversizing the valve itself.
Exactly.
This is a high pressure, non-compliant balloon, 24, and this is as recommended. We have to have the final best opening of the valve at the final stages of the procedure.
Sorry, I wonder because you don't have a gradient. It looks like valve is functioning, so post-dilation is just mandatory for the long-term results. So.
Yes,
Correct.
exactly.
Okay.
In order to be symmetrically.
Because we still see that there is an indentation of the stent at the middle part of the stent. So we try to get the best possible result after the procedure. Otherwise, it's going to be the duration of the valve will last shorter. All right, so now we can place the pigtail into the pulmonary artery, do the angiogram from PA, and then one angio from right ventricle, coronary angiogram, and I think we are done.
And you have there an aneurysm of the pulmonary trunk?
There is no aneurysm,
It's
just
dilated.
dilated,
Yeah.
correct. It was a poststenotic dilatation. As we can see here, that the narrow part of the conduit was just where the surgery was performed, and the distal part of the pulmonary arteries were quite healthy.
Stop. We are going to cross the valve now with the pigtail.
We can place the pigtail on the wire.
Yeah.
Yeah, all the time. Ah, you mean the Lunderquist?
Correct.
Yeah, it's also possible.
It's easy.
Yeah. You're right.
In fact, you will have two pigtails and you can just record a gradient and something.
Correct.
If it's important.
Correct. That's
Absolutely.
the idea.
Absolutely.
Ние имаме втора крива, нали, Поли?
Because I think that this pigtail is stuck in the tricuspid, so we have some arrhythmia. I think it's better to take this out and then
And to put on the
on the
Lunderquist.
Lunderquist. Correct.
Absolutely. Yeah, we'll do that. Okay, I'm removing. Now, yeah. Probably stuck.
I'm very curious about the coronaries, but from the ECG on the screen, I don't see any signs of the ischemia.
No, the ECG is absolutely the same.
And the blood pressure of the patient is 135 and 80. So, and it's still increasing.
Yeah, it speaks about.
Ivo, I wonder, because in TAVI procedures, if you want to protect the coronaries, usually you put a wire in there and you keep it until
Exactly.
the end. So why not
Exactly
do it in this
this.
way?
Because we were absolutely sure after the several injections that there is no compression. But in fact, we were prepared and we are prepared with everything, with guiding catheter, with wires, with stent grafts for chimney and so on.
So we choose the guiding catheter AL2 just in case if we need to place the stent, and we started with the with AL075, which was quite too small. So we took the different guiding catheter. Just be ready for the intervention.
We can make a direct gradient measurement now between the two pigtails. Probably after taking a zero, new zeroing. Now. Давайте 0 на двете. Excellent. I see one line. Now we have 0.
But still only one line.
Okay, one line. And this is the measurement from the pigtail in the pulmonary artery. And where is the second line? Where is the measurement of the second line? Okay. We have one line.
One line.
We have one line, and I will switch now the measurement line from this pigtail after registering the pressure. We can go to scale 50, please, if possible. Давайте на скала 50. It's 26 by 9 numerically.
Mean is 16.
And mean is 16.
Having in mind the right ventricular function and previous gradients, I think it's a quite good result.
It's excellent result.
Let's check
definitely.
the pressure in the right ventricle and then we'll see how did we.
Yes, and this is now the same line on the other, on the pigtail in the ventricle. It was 26 by 9.
Congratulations.
Here is, yeah, the gradient is some kind of 5. The peak gradient is 4.
So we think, and if we have a single-digit gradient after this procedure, it's a very good result.
Yeah, it's 4. The gradient is 4.
Perfect. So now we just need to be sure that we are not compressing the coronaries and that we don't have any extravasation.
Exactly, absolutely.
So the coronary was somewhere in the corner between the sternum wire and this indentation.
Yeah. Yeah, дай ми, тя беше... Я ми пръстни да прям. Не. Още една спринцовчица. Ето тук. Okay. Just лекичко. Дай ми снимката в тая проекция на коронарната артерия. We'll take a look at the...
I think it was area
Yeah,
37,
this one.
cranial 30.
Yeah, I want this projection. It's 37 by 13.
Correct.
Okay.
Yep, right here.
Лекичко. Цък. Okay, we are ready probably to make coronary injection separately. Давай.
All right.
Great.
Can we also
No
go to the
compare.
bullseye projection, caudal?
Давай още една, другата проекция. Каудалната.
Try to see the valve in the short axis and all right.
Yes, okay. Excellent.
All right, good.
Yeah. Okay.
Can we? Yep.
Go.
Nice.
Nice. No compression at all. Okay.
All right.
Congratulations. Congratulations.
Thank you.
Not bad.
That
Not
was
bad.
really
Thank
Okay.
you. Excellent. Thank you, my team. Thank you, the audience. Okay.
Final анджио да направим от пулмонализис.
Давай, final Анчо.
Само.
Let's go areocranial.
Even just before you're finishing, how would you intend
Yes.
to close the vein? It's just 8 stitch or something else?
Yeah, figure of eight. Figure of eight.
Figure of 8. Okay.
Yeah, figure of eight on the usual way. And artery with angiosil. Ready for final injection here? Go. Excellent.
No regurg.
No regurg. So everything is checked and it's good. Okay, go.
Perfect.
Perfect. So we are going for figure of eight. Okay, we are removing the pigtail and going for figure of eight. Голяма игла с дебел конец, неразобируем.
Can you take this one?
Как е да ги махам?
Ми да.
Това е 4 френча, така че ще го...
Значи нищо няма да му слагам. И на вената естествено нищо няма да изслагаме, така че... Не знаех, че 4 френча сте сложили. Яко, браво.
Това е 4-5.
Това е 4 дета. Яко. Какви сме отворени.
Ivo, thank you so much for the beautiful case. We think we are moving now with the program and we will be leaving you to close the vessel. I think it will not be a big problem for you. So thank you, and you are moving forward with Dr. Polomsky. Shall be presenting a speech about how to perform a supra-selective vein sampling.